Good morning, everyone. Today I shall be presenting the clinicodemographic and etiological profiles in acquired esotropia. I have no financial interest to disclose. The primary objective is to study the clinicodemographic profile in patients with acquired esotropia and to report the varied etiologies. It is also to determine the functional outcomes in these subset of patients. Acquired esotropia can be acute or chronic in onset with variable progression. The prevalence is around 10.4% of the total diagnosed esotropia cases. Acute esotropia can be comitant or incomitant. In the comitant variety, acute acquired comitant esotropia is characterized by an acute onset of esotropia with an equal angle of deviation in all fields of cases. As per Burien-Miller classification, there are 7 types of acute acquired comitant esotropia. In the incomitant variety, it is an esotropia with varied angles of deviations in different cases. Acute esotropia may present as have variable etiologies like ischemia, trauma, etc. The study was a prospective study conducted in the Department of Ophthalmology in KIMS Bhubaneswar with a sample size of 21. Detailed ocular and systemic evaluation of all the patients was done with ocular and laboratory investigations wherever applicable. The inclusion criteria took diagnosed cases of acquired esotropia with an age range of 5 to 55 years and excluded severely ill patients or patients admitted in ICU. It also excluded infantile esotropia patients and patients with history of previous ocular surgeries. These patients were followed up for first, second, third, and 6 months. The statistical analysis done gave us a p-value less than 0.05%, which was considered as statistically significant. On demographic parameters, the mean age was 32.3 plus minus 0.36 years, and there was a male preponderance in our study participants. The most common presentation was bilateral. On best corrected visual acuity in logMAR units, we found that there was a significant improvement in vision starting from presentation to 3 and 6 months of follow. Coming to etiology, neoplastic etiology was the most common, followed by post-fever and ischemic etiologies. On laboratory evaluation, deranged serum homocysteine lipid profile, ESR and HbA1c was noted in ischemia, whereas in idiopathic intracranial hypertension, there was decrease in serum iron and ferritin levels. On OCT, there were 43 patients had RNFL thinning, whereas 36% of the patients had RNFL edema and thickening. On CSF analysis, 20% of the patients had viral meningitis, and 26% of the cases had CSF suggestive of malignancy. The neuroimaging was also performed. MRI brain and orbit with contrast, along with MR venogram with contrast was done wherever needed. And the raised intracranial pressure was the most common finding, followed by hyperintensity and enhanced lesions in meningioma. We also performed HFA in 24-2, where advanced field loss was the most common finding, followed by enlarged blind spot and inferior quadrantopia. So in some patients, due to poor vision, the fields could not be obtained, which was 26% of the patients. Coming to discussion, in the study done by Clark and Nelson et al., acquired esotropia was found to be secondary to refractive errors, decompensated esophoria, and prolonged near work. In the study by Buick-Winding et al., it attributed to elevated intracranial pressure, tumors like glioma or Arnold-Chiari malformation. Cerebral and thalamic tumors were also a major etiology. In the study by Liu et al., in 30 children presenting with acquired esotropia, 12 had comitant esotropia, whereas the rest 18 had incomitant esotropia. In our current present study, neoplastic origin was the most common, followed by infective and ischemic etiologies. So the take clinic message from my presentation is that majority of the patients presenting with acquired esotropia have neoplasia as a major underlying cause. Patients with refractive accommodative esotropia are orthophoric at final follow-up after using glasses with good compliance. A detailed history, thorough clinico-radiological evaluation, along with adequate lab investigations will help us in clinching the appropriate diagnosis at final follow-up. These are my references. Thank you.
Required complete workup, yes, and especially the neurological, and that's what you mentioned, which is very well known for a long time, because that is something we can't ignore at all. So what really you wanted to convey, which could give us little additional information in your study?
Sir, our study combined all kinds of etiologies so that understanding the underlying cause, we can provide a better inventation on a quicker time as compared to delayed presentation. So that if we understand the underlying etiology, it will lead to a better patient care.
Subhangi, excellent contribution at least from refractory error to ICT to neoplasia you have said. I would have appreciated in a competitive session like this should show pictures also. You see, none of the picture I could see, neither OCT, RNFL thinning, and HFA or some neoplasia evidence. You see, whenever you present, you should show यहाँ पे neoplasia था, RNFL thinning ऐसा था. So that will add value to your. Plus, do you think that once we're talking of clinico-demographical and etiological profiles, 21 patients are good enough?
No, sir, the scope
This
could be
too,
widened further.
Because 21 patients and drawing such a big conclusion, थोड़ा सा sample size बड़ा होना चाहिए.
Yes, sir. Thank you, sir.